Hi guys, welcome back to another video. This is Dr. Douglas Gillard. We are on a continuation of embryology videos right in a row. This is video number 9. We are now going to talk about something very important, and that is the folding of the flat embryonic disc. And this is the classic, we're going to create the classic, and all the authors say in various words or another, the classic tube within a tube body plan or phenomenon or whatever you want to say. So here we go. Okay, a little review here, and I'm not going to go crazy on this if you haven't watched all the other videos. If you've watched all the other videos up to this point, understand them, you are going to be an expert embryology student because we're going quite deep into this stuff and plenty deep for any medical, chiropractic, physical therapy board. So this is kind of a side view, which is called a sagittal view or a median view. And remember what we've created. We've created a fairly flat embryonic disc, and this is the fetus, or this is not the fetus yet, but this is the embryo. This is the little baby tiny human. And we've got a 3-layer disc created. We created an endoderm, which has some special cells. I don't think we need these cells. Intervisceral endoderm cells, we don't need those until we start talking maybe about formation of the heart and circulatory system. But we created an endoderm. We have an ectoderm on the top. Now part of the ectoderm is filled up with a primitive streak that has been growing caudally toward the cranial aspect this way. And then we had a mesoderm created not too long ago, and here's some red mesoderm cells, and this is a very mid-sagittal section, so we also see a nodal cord that has formed. And the nodal cord is just about going to give rise to a neural plate right over here, which is going to turn into the neural tube in a little bit. Okay, some other important things. Remember that we have an amniotic cavity. This is going to be really important. In fact, let's blow this up a little bit bigger here. We have an amniotic cavity right here that's going to grow like crazy in the start of the 4th through the 4th week to create folding. Remember, the amnion is what circles or lines this amniotic cavity. We also have a secondary yolk sac. By now, authors just call this the yolk sac, but technically it's the secondary yolk sac, or a definitive yolk sac, if you will. That's used to be surrounded by Hauser's membrane, but that is pretty much long gone. All the authors have forgotten about it. So at this point, it's best that one of the authors just calls it the yolk sac membrane. Not super important at this point. And remember that we had a solid layer of another mesoderm created that filled outside of this secondary yolk sac, and that secondary extraembryonic mesoderm split. A cavities formed within it, and it split that mesoderm, not the intraembryonic mesoderm, but this is an extraembryonic mesoderm. It split. This huge cavity developed, which is called the extraembryonic coelom, or extraembryonic cavity, or chorionic cavity. And it grew and it grew and it grew, and it basically created 2 new layers, a splanchnic and a somatic extraembryonic mesoderm. So this is the official word, is the extraembryonic somatic mesoderm. Some authors, including Moore's, which is a chiropractic board of examiners used book, they call it parietal. He calls it parietal mesoderm, extraembryonic parietal mesoderm. And then we have the extraembryonic splanchnic mesoderm. So those are going to be important because we're going to talk about a gut tube and things like that. So it's important to remember. Okay, and we'll see, because there's intraembryonic lateral plate mesoderm, but we can't really see it on this view. I think that's about all I need to say. And notice that these extraembryonic coeloms, they didn't completely meet. There's a little stalk of tissue here that wasn't plowed through by the development of these things. This is going to be the future umbilical cord right here, and right now it's just called the connecting stalk. Okay, here is that kind of cross-sectional view, or horizontal view. Remember the hat analogy, horizontal, axial, transverse? They're all the same. A lot of embryology authors call this the horizontal view, but it's a cross-sectional view. Now we can see stuff really good. Recall that we can still see the endoderm. Here's the neural plate that's forming above the nodal cord here in black. We have the endoderm right here, ectoderm here. Remember, the mesoderm at this point has split, kind of grouped into three. The last video was on this important kind of differentiation of the mesoderm. We have a paraxial mesoderm, super important. We talked about how that differentiates into a dermatome, myotome, sclerotome. Sclerotome makes what? Sclerotome makes the spine and the ribs and the dural coverings, or the meninges, super important. Intermediate mesoderm, lateral plate mesoderm. Now this is important for this video. The lateral plate mesoderm split into two pieces. A somatic lateral plate mesoderm, which merges right into the somatic extraembryonic mesoderm. And then we have a splanchnic lateral plate mesoderm was split. Remember, it's kind of the same with the extraembryonic mesoderm. There's a cavity that grew in here, remember that? And that's the intraembryonic coelom, and it grew so big it actually ripped right into the extraembryonic coelom, which is all the space out in here. Here's the intraembryonic coelom is right here. But out here, like this region, is the extraembryonic. So for a short time they communicate, but not for long. But this splitting created two layers, a splanchnic and a somatic lateral plate mesoderm. But that morphs into the ones we were just talking about on the other side, the splanchnic or visceral extraembryonic mesoderm and the somatic extraembryonic mesoderm here. Okay. All right, so that's the review. Let's get started on this video. So folding of the disc, creating a tube within tube design. So during week 4 of the embryonic disc, and associated structures will grow like crazy, especially in the horizontal plane. They grow laterally out from the midline. And this causes our flat embryonic disc to get bent under or fold under toward the ventral surface of the embryo. While this is going on, we already talked about neurulation, but neurulation is happening at the same time that this is going on. Folding happens in two planes, the horizontal and the sagittal plane. The horizontal, or that cross-sectional plane, that gives rise to what are called the lateral folds. These are arguably, well, they're all important, but these are super important with regard to some pathology that we need to learn. And then in the sagittal plane, we have a fold in the front region, the cranial region, called the head fold, and a fold in the back region called the tail fold. We're going to look at lateral folding first. So horizontal folding, meet the lateral folds. Remember, these lateral folds, they could be called, the process of making the lateral folds, they're always called the lateral folds. But the process of making them could be called lateral folding by the authors. It could be transverse folding. It's commonly used. Axial folding, cross-sectional folding. These AKs drive you absolutely crazy, don't they? But at least if I want to put that out there, so if you read, you won't be confused by it. So let's meet the lateral folds. So mainly the ectoderm, amnion, and amniotic cavity just start growing laterally like crazy. The endoderm doesn't, and therefore the endoderm kind of acts like a pivot point around which the growing ectoderm and amniotic cavity kind of gets bent because of the slow growth of the endoderm. These folds again are called lateral folds or lateral body wall folds, best demonstrated in the horizontal plane. Again, don't forget HAT, AKAs are horizontal, axial, and transverse. I said that already. Or some other AKs, cross-sectional, anterior to posterior, posterior to anterior. These are all AKAs. Okay, so here's our nodal, or here's our little embryonic disc would be right here. This is the whole thing though. Secondary yolk sac, amniotic cavity. Kind of a horizontal view. We got a little bit of obliquity in here. It's a little tiny bit toward the sagittal, but mostly a horizontal view. And I went over all this. I'm not going to go over this again, but the key of this is this blue stuff. That's ectoderm. It starts growing like crazy this way, and this side grows like this way. And the amnion and amniotic cavity start growing. The endoderm doesn't grow that much. It grows, but not so fast. So this grows faster, and it starts to bend the sides around. See how this is happening? The endoderm has hardly grown at all, yet the ectoderm is growing like crazy. So it bends it, and it's actually going to bend it and poke it right back toward the midline here in a second. So everybody's good with that? That's the first start of this growth. Okay, and then now we can name all the components again, because things are starting to get a little screwed up. You're not used to seeing them in different dimensions, but the blue is still the ectoderm. It's growing like crazy. The amniotic cavity is this thing. The lateral fold is right here. This piece right here these are called the lateral folds, and they're moving down. Endoderm is still the same. Notochord is still the same. This is the paraxial mesoderm. Somite, I should have taken that out because we need to be more specific. This is the paraxial mesoderm. Oh, I see, it's mislabeled. Paraxial mesoderm is here. This is the intermediate mesoderm. Sorry about that. Intermediate mesoderm is here and here. And then the lateral plate mesoderm has already split into its two components. This piece would be the somatic or parietal lateral plate mesoderm, and this piece would be the splanchnic or visceral lateral plate mesoderm, and these both morph into extraembryonic mesoderm, specifically extraembryonic splanchnic mesoderm, and extraembryonic right here is extraembryonic somatic mesoderm. Everybody good with that? We got our intraembryonic coelom is right here. The extraembryonic coelom is kind of floating out in this region here, right? So let's keep bending. Next, the growth continues so much that it can no longer go downward and actually comes back toward the midline to pinch the midpoint of the secondary yolk sac. Picture is always best. So now remember we were right here? So now the folds have grown in like that, and we're pinching in that secondary yolk sac. Look how pinched it is. Still very developed here, but now it's pinching right in the center of it. Notice how the endoderm now is almost completely folded, and this is going to give rise to our gut tube, as we'll see here in a second. And I don't want to get too far ahead of my slides. But this gut tube will develop into the foregut, midgut, and hindgut, which is from the mouth to the anus. It's everything. Our stomach gives rise to our lungs, our trachea, tracheobronchial tree. Super, super important. And who's in the very middle of it? The endoderm is. So the endoderm forms the gut tube. There was, actually, if you get technical, there was another layer. You can see I left a little yellow here. That was that yolk sac, that lining of the yolk sac cavity, and not a single one of the authors talk about what happens to that. So really that was the deepest, but all I can surmise is it just degenerates away into nothing. Because for all boards and all testing, the endoderm is what lines the gut tube. Good? Okay, then the lateral folds flat out. So here we haven't quite come together, right? This is a huge lateral fold, but they're gonna pinch this thing. They're gonna come straight up together and completely fuse, and so that's what happens. So at the end of week 4, the continued growth of the amniotic cavity and the players we've mentioned basically pinches together, and the right and left lateral folds literally fuse together. And as they do so, they create some new structures. Flat out create an anterior body wall, your thorax, your abdomen, your pelvic in the front is all created by this lateral folding. They create a gut tube, and we're going to look at all these specifically. They create a body cavity, and in the very center, they create the very center in a sagittal plane, the very midpoint of the embryonic disc. The lateral folds do not completely fold together. They come very close, but they don't completely pinch off the yolk sac. And that makes a little channel between the yolk sac, secondary yolk sac, and the gut tube, specifically the mid portion of the gut tube, or the midgut. And we'll look at that. But that little duct is called the vitelline duct. Vitelline, that's got a whole bunch of AKAs. Okay, so here I guess we're just going to go through it again. Amniotic cavity is going, it's coming, we're pinching together, and boom, now we have pinched completely together. So this picture would be good for anywhere in the former embryonic disc, which is now bent, but not in the very center, because that doesn't fuse like this, but everything else does. So now look what's happened. We have formed a gut tube completely surrounded by the green endoderm we looked at. The ectoderm now completely, which is going to become the skin, right? Because that's the very out. This is all of this stuff. This is the body. All of this stuff. Really, there's the neural tube. Most of it's going to form from here, but so it's surrounded by the ectoderm layer. Endoderm layer is here. The mesoderm layer, we can see the lateral plate mesoderm are layers. Here's our here's our somatic lateral plate mesoderm that goes on to line this cavity which has been created. I'm getting ahead of my slides here though, but this piece right here, all of that's the splanchnic lateral plate mesoderm. So that kind of forms the wall of this gut tube. And what happened to our intraembryonic coelums? What happened to, let me see if I can find a good picture. You can kind of see them here. There's a right and a left intraembryonic coelums. Remember, here's a better one. They came from right here, these regions. See those? Those go all the way over and now fuse together. So they're fused right here. So now we have one big cavity. And that's going to be basically the body cavity, the thoracic cavity, the abdominal cavity, and the pelvic cavity will all come from this. So we've created a lot of stuff. The amniotic cavity has also fused together here, and it's formed the anterior body wall. So this is placenta. It's going to be, and we'll talk about that later. So this is going to disappear, but really this will be the anterior body wall, but it's still fused together. Okay, and we're going to talk about, and boards love this stuff, what happens when it doesn't fuse together. We get all kinds of birth defects, so that's going to be important. Okay, so everything I just said right there, you can read that. Here's more specifically everything I said, I just labeled again. I don't think I missed anything. No. Okay, and this, by the way, this is the very end of week 4. So we've went through 4 weeks. This is just the end of week 4. We went through 7 days to create this. Okay, the fusion of the lateral folds, as I mentioned. So this is everywhere except the very center of the embryonic disc. It doesn't look like this. So at that center point, fusion is incomplete. And lateral folds have come close, but they've left a tube communicating with the yolk sac and the midgut, and that's called the vitelline duct. Complete fusion did not occur. It will occur eventually, but not for quite a long time. So let's go down and check out this vitelline duct. Now be careful with these AKAs. Omphalocele is one of the pathologies we're going to look at. So one of the AKAs is omphalomesenteric duct, a very strong AKA for vitelline duct. There's omphaloenteric duct. There's the vitalointestinal duct. Some embryology authors just call it the yolk sac. So I don't know what to tell you on boards because I don't know which one they're going to use. I'm going to guess vitelline duct, but the board authors use this word as well as omphalomesentéric duct, so you're going to have to know some of these AKs. Again, it's an incomplete folding in the middle, and here's our vitelline duct. You see how the gut tube is open. This is actually will be the midgut, and we have a communication, and then we have a yolk sac. Now in animals and other mammals too, but not in humans, this is filled with yolk, like the yellow stuff in an egg, and that yellow stuff gives nutrients to all these growing cells. But we're going to develop a circulatory system. Matter of fact, that starts in week 3, and that'll probably be the next video. So that's already well underway in feeding this tissue. So we don't have yolk here, but so it's kind of a remnant. Right? So say goodbye to the vitelline duct. So if we jump way forward to week 7, normally that duct completely, the gut tube closes off completely, the body wall closes. This is all at the this region is the umbilicus. The belly button is right here. The lateral folds will pinch up to something called the umbilical plate and the umbilical ring, and they'll fuse to that. The key is normally. That happens week 7. It could be anywhere from week 5 to week 10. Week 7's on average. Now, pathology time. If it doesn't completely degenerate away, we can have some troubles. So that the remnants of what's left of this vitelline duct, this whole thing, it's fairly long, and it's eventually going to connect the intestine. As it's developing, it connects the ileum, specifically the distal ileum, to the umbilical plate or the umbilical ring. That thing needs to disappear and get out of the way. It'll tangle up intestines if it doesn't. And other problems occur. All sorts of problems occur if it doesn't degenerate away. And so, and this is a big number, 2% of infants have some sort of persistent vitelline duct. And it may be asymptomatic, but it could cause trouble in that newborn infant. We need to look at that. In fact, it is the #1 congenital anomaly of the gastrointestinal tract, and that's a great book, Schlesinger. I use that in GIGU. So this is #1. So this is high yield board stuff, in other words, medical and chiropractic. You got to know these things for medical and chiropractic boards and physical therapy boards. So let's talk about it. A persistent vitelline duct pathology? Yes, there is. So the persistence, a failure of degeneration of the vitelline duct, it should be gone by week 10 at the most, but by week 7, it can result in several different congenital abnormalities we need to talk about. By far, if you only have time to memorize one of these, memorize this one. This is a Meckel's diverticulum, and that's by far the most common. Up in some research says up in 4% of newborns have this problem. May be asymptomatic their whole life, doesn't mean it, but 4% have one. So may or may not develop into trouble sometime at some point in their life. There's a vitelline fistula, a vitelline cyst. There's a vitelline ligament that can develop. So let's go through some of these. I'm not going to go all of them. But here's the distal ileum. So now we're way into week 7 or so. And this distal ileum is supposed to be by itself. There's not supposed to be any communication between it. Here's the belly button. And here we have what's called a vitelline fistula. We have a communication between the inside of the distal ileum, that's the distal part of the intestine, and the belly button. These people can have fecal material and ground up food actually leaking out of their belly button. Sometimes it turns into a scar tissue on both ends, which shouldn't be there either, but only the center is left patent and open. And there can be some weird tissue in here, even some stomach acid tissue or stomach gland tissue that secretes acid, so you can get trouble within this. This is called a cyst, a vitelline cyst, or an omphalomesentéric cyst. These are AKAs. Or sometimes it tries to degenerate away, so at least it's not a hollow tube anymore, but it didn't completely. So you get this fibrous band called the vitelline ligament, or the omphalomesentéric ligament. And it may not cause any infection or anything, but it can get, your intestines can get entangled around it, and we'll look at, and can cause obstruction. We'll look at that. But the first one, so that was kind of a review. Here's the vitelline fistula, and let's take a look at this. So this guy, he's actually, usually you would catch this during embryological times, but here's a rare case when an adult actually developed problems. The vitelline fistula became active later in life, and you can see there's like a juice kind of dripping right out of it. It's connected up to his distal, the distal ileum, and he's also got an infection. Look at all the red around here. So this occurs when the vitelline duct remains patent, just like this. Okay, got it? That's what he has. It forms a channel, may result in seepage of intestinal contents. Did you notice the erythema? That's redness. There's some redness around here, so there's an infection going on underneath that. Here's the vitelline cyst that we talked about. And not much to talk about really about this. I think I said it already, but you have a vitelline ligament on each side, but you have a cyst here. Maybe there's a tiny communication here, and you got some fecal material in here. Maybe you got some gastric glands growing inside here, secreting acid, and it burns a hole in this. That causes an inflammation, could cause peritonitis. The biggest problem with this is could probably cause small bowel obstruction. You can get intestines wrapped and tangled up other intestines. This is just one, right? There's intestines are smashed in here like crazy, so it could get all twisted around. Now we're going to slow down and talk about this one. This is the big one. This is a Meckel's diverticulum. It is a outpouching of the distal ileum. So here's the distal ileum just before it reaches the ileocecal valve. All this stuff you'll learn in Gross 2 anatomy. That's again, I might go off on a tangent here, but I don't want to. But I should mention that embryology has no business being in first quarter. A lot of this stuff, it would be better in third quarter after you've completed Gross 1 and Gross 2 anatomy. So why they put it in first quarter, medical students, I was in first quarter medical school myself, and guess where it was? Right in first quarter medical school. And when I was in chiropractic college, it was in first quarter as well. So, but it's administrators put this in third quarter if you really want students to understand it. But anyway, Meckel's diverticulum, it's almost like a little appendix, isn't it? It's a outpouching of the distal ileum, and the lumens communicate. So it's almost like an appendix, right? It's the vitelline duct, which failed to generate away. It started to degenerate. Vitelline duct used to connect to the umbilicus to here, and that's gone, but it didn't go all the way. So sometimes you'll have a ligament connected here as well. Sometimes you don't. This picture you don't. This picture you do. So here's a Meckel's diverticulum. Here's the distal ileum. Here's the mesentery, which anchors the intestine to the posterior abdominal wall. And here, this didn't atrophy, so now we got a vitelline ligament. Here's the belly button right here. Now this one's not going to seep fluid out, at least, but you can get stuff tangled up here, and we'll look at the different pathology which can occur because of that. Here's a real one intraoperatively. So it looks like a little appendix. Here's the distal ileum right here, and they're fixing to get rid of this thing. Occurs in about 2% of the population, slightly more common in males, and accounts for 2/3 or 67% of all congenital pathology of the gastrointestinal tract. Congenital pathology related to a persistent vitelline duct. So if something goes wrong with a vitelline duct, 66-67% of the time you're going to get a Meckel's diverticulum. Okay, it's about 5 centimeters long. One really weird thing about it, now this is, again, if you've had Gross 2 anatomy in second quarter, you understand this more. But histology, you're learning probably about it right now, or maybe you've learned about it. This is the epithelial lining of this is columnar epithelial. And there's no stomach glands in here. There's no parietal glands or anything like that. But in these, for whatever reason, in these diverticulum, you can get stomach glands growing in the walls. So instead of intestinal glands and mucus glands, and things like that, you got real gastric glands growing in here, and they can secrete hydrochloric acid. And is that a good thing to secrete acid in this little tube? No, because you can't. It can accumulate here and start to burn a hole in the lining, and now you got an inflammation, and the thing can start bleeding once you get deep enough into the wall of this thing. So guess what one of the most common signs is? Rectal bleeding. It's very common. Most common first symptom is rectal bleeding from this, and that means it's probably got gastric mucosa. It could have mucosa from the and glands from the biliary system, the duodenal system, the colon. Even pancreatic glands have been found in here, but 83% of the time they're gastric. So, and that causes trouble. So as I just said, this I should have warned you, huh? Gross slide. Warning. The most common cause is a maroon color blood in the stool or poop or on the toilet paper or whatever. You guys need to know these words if you don't. Melena, that's a stool. I didn't show you a picture of one, but it's black. It looks like tar. That means the bleed in the intestinal cavity has come from way up, maybe in the duodenum or I don't know, way up the upper GI system. When it gets super red or maroon red or any color red, like this is maroon red right here, that's even a little brighter red here, that's called hematochezia, or and here's my pronunciation, guys, hematochezia. And that's a bright red color in the bowel as opposed to black. So that's the number one symptom, hematochezia. Bright red would be coming from closer, like the rectum or sigmoid colon or descending colon would produce bright red blood. Usually this one is up a little further, so you get a maroon color. Where's the blood come from? We already said you get a peptic ulcer. Now you only see those in the stomach and duodenum. How in the world can you get a peptic ulcer in the Meckel's diverticulum? Well, I just told you that means you have to have gastric acid or the glands, the parietal glands that make acid and pepsin are actually here, and there's nowhere for it to go, so the acid piles up and burns a hole, and that's an ulcer. So you get a peptic ulcer from that. What about death? I mean, it can surely happen, but a lot of times what happens is the child gets really, really sick. It gets infected, and they get an acute abdomen, and they probably misdiagnose it as appendicitis, but they get treatment. But they do start to become quite dehydrated, and that turns into a hypovolemic shock. But once the hypovolemic shock, that turns on your sympathetics. We'll learn about, you'll learn about too, my tiger, the vasomotor center and the medulla is like a tiger cage, and the tiger is the sympathetic outflow. Sympathetic outflow hits the tunica media of the splanchnic arteries, and it basically shuts off the bleed as a life-saving measure. So bottom line is the kids usually don't die from this, but they get very, very sick. Now, what's the second most common? We said bleeding is the first hematochezia is the first problem. The second one is intestinal obstruction. Now, this one can be even more dangerous than the bleeding. It is definitely more dangerous than the bleeding. So many of these diverticula still have a ligamentous attachment to the umbilical plate, and that cord can get tangled up. And there's two, now this is high yield board stuff, you got to know these two. There's two types of entanglement that can happen. There's a volvulus, which is an entanglement, we'll look at a picture, and this is a weird one called intussusception. And so this, if the child is over 4 years old, this is almost, and they are diagnosed with intussusception of the small bowel, it's almost always due to a Meckel's diverticulum. So super common. Okay, a volvulus. So here is our Meckel's diverticulum right there. See how it got twisted? This little finger, I guess I should have kind of drew that bigger, but it got twisted, and it was a kind of twisting point, and it twisted the bowel. Well, so what? Who cares if the bowel gets twisted? Well, first of all, you got poop going through there, or soon to be poop. You got digestive material going through, and you don't have it anymore. It gets stuck. It looks like it got through in this drawing. It's all stuck in here. That digestive material is filled with bacteria. Those bacteria multiply, multiply. Pretty soon you got a rip-roaring infection and inflammation going on in here. And if that's not enough, how about the veins? You got in the, it's not drawn in here, but you have mesentery, that arteries and veins travel to service these tissue cells. All these intestines is made up of cells, all sorts of cells, and it needs food. It needs blood and oxygen. It needs to have its waste taken away. Waste is taken away by veins, and the veins are all kinked. And so now you got a backup of waste and acid in here to make things even worse. That causes something called ischemia. This tissue is going to start dying and rotting and get brittle, and then you're going to start breaking holes in it. And you can bleed, and you can get poop into the peritoneal cavity out here and get peritonitis, and that can lead to septicemia, and you can die. So we'll talk way more about that in GIGU in 5th quarter. But that's a Meckel's diverticulum related volvulus. Now here's a weird thing. This is a Meckel's diverticulum over here, and it's acted as what's called the lead point for intussusception. And intussusception means that this part of the intestine holds still and doesn't move, but because of peristalsis, the part that is upstream or proximal to it, it's kind of driven or ferreted right inside a tube within a tube. It's not supposed to be here. And so that's the intussusception, and the same thing. You got blood vessels in here getting pinched, and you got ischemia occurring, and just a very dangerous situation. Okay, obstruction is a medical emergency. Everything I just said. The twisted intestine can become strangulated, which leads to no blood flow for the tissue of the downstream to the strangulation. So you get ischemia, necrosis, death, perforation of that tissue, and you got big trouble. Septicemia can occur. Very dangerous. That can kill you. Patients will suffer severe abdominal pain, abdominal distension. Their belly will teach you how to percuss, and when you percuss their abdomen, it'll be like a timpani or like a drum. It'll be so loud. They'll be throwing up this weird green bile stuff called bilious eminence, and they can go into hypovolemic shock real quick from this. We'll talk about that more in GIGU. And then another thing that can go wrong is the diverticulum can develop an inflammation. So a diverticulum inflamed is called diverticulitis. So Meckel's diverticulitis is another problem. And let's go back to, where's that one? Let's go back to this to talk about this. Oh, we can use this right here. See, there's a lumen right here. This is like a dead-ended part of the intestine. Here's the distal ileum here. But what happens if you're eating a whole bunch of seeds and a big seed gets plugged right here? That seed can block, which I didn't draw in here. You have blood vessels in the wall here coming out. Blood flows out of this, and you can plug those blood vessels up so they can't, no venous return can come out of here. That can make this start to swell anymore. And then it traps it. The seed traps all the junk in here. So you got some fecal material down here, and the bacteria can start dividing and going crazy, and pretty soon you got the bacteria invade the wall of the diverticulum, and now you got a wicked inflammation, and it can eat a hole right through. This is not very thick. You can eat a hole right through that, and now you got yourself peritonitis, and inflammation of the peritoneal cavity or the peritoneal cavity, however you like to say that. Okay, so medical emergency. Okay, food particles too, little kind of pre-poop balls can plug that up, and that's the same for diverticulum, diverticulosis, which we'll talk about in GIGU. Okay, here's one section that was taken out of a young patient who didn't make it, but you can see the diverticulum looks like the appendix coming off the cecum. of the large intestine, but it's not. That's a Meckel's diverticulum. Out of the rabbit hole now. What else does fusion of the lateral folds create? Well, we said it created a body cavity. We kind of talked about this already. But here the intraembryonic coelums have actually, the right and left have come together and the wall has dissolved, and now we flat out have a body cavity. And that's going to be our thoracic cavity, our abdominal cavity, and our pelvic cavity. Sometimes it's called the primitive body cavity or the embryonic body cavity, but body cavity will be in there. What's it created by? That's a good question. What the primitive body cavity is lined by what? I can see that question coming in my embryology class. What's this stuff, this red stuff? What is that red stuff? That's the lateral plate mesoderm that's split. So this is the one more to the outside. So this is the somatic lateral plate mesoderm. That lines it, except here, that's the splanchnic lateral plate mesoderm that lines it here. So lateral plate mesoderm is what lines the primitive body cavity. I think I got way ahead of my slides. A body cavity is lined by a lateral plate mesoderm, primarily by somatic. We just went through all that, so I'm not going to say that again. But a little bit of splanchnic lateral plate mesoderm would be right in this region, is here too. It also creates some, well, we'll talk about that. I'm getting too far ahead of my slides. Okay, so I've heard this before, an author saying this, the cavity, the body cavity is roofed by what? What does that mean, the cavity is roofed by? Well, there's roofed and lined, if you hear that. It's lined by lateral plate mesoderm. So the roof would be the outer layer of it. And that is our ectoderm, right? See, here was this was our ectoderm. Oh, it still is our ectoderm. There's the neurotube, notochord, dorsal aorta. We're going to talk about that, I think, the next video. Lateral plate, or the ectoderm grew like crazy, and it grew completely around this, but that forms the roof, so to speak, of the primitive body cavity. And now it forms the inner lining of this crazy big amniotic cavity, which is now surrounding the whole embryo. Are we good? I think we're good. I wanted to mention here too, with this, back to this lining of the body cavity. So notice that we have, it doesn't show it here, but this is double layered. So we have, this would be the, I guess, reading left. I guess the body would be the right, but this is one side of the lateral plate mesoderm, the splanchnic lateral plate mesoderm. This would be the other side. So this is a double layer thing that actually holds the intestine in place, and that's mesentery, it's called. What else does the fusion of the lateral plates create? Gut tube. We've talked about this, but let's look a little bit more. So lateral folds come in, they pinch, as we said, the yolk sac into a ventral and a dorsal component. So the dorsal part of the yolk sac, so here's the ventral, this is ventral down here, dorsal up here. So ventral yolk sac, dorsal yolk sac is created by the lateral folds pinching in. So up here, the ventral portion of the yolk sac is going to form the gut tube. And remember, in the center cut, in the sagittal plane, the center cut stays open as the vitelline duct. But the other plane, the anterior and posterior, they completely close, but not this center part. But that's the gut tube. So here's a cut through, more cranially, through the embryonic disc. And you can see we talked about this already, that's ectoderm. So by week 7, the fusion of the right and left lateral folds created the gut tube. Classically, it's said to be lined by endoderm, as we said. I mean, this is my side note. Really, it's lined by secondary yolk sac lining, which must have just generated away. I couldn't find none of the authors said what happened to that, but that's got to be a given. The embryonic, or the outer wall of the gut tube is made by, what is it made by? Let's blow this back up. So what is the inner wall is made of the gut tube. The inner wall is made up by endoderm. What about the outer wall? Or the roof? It's roofed by what? Well, we already said that's the lining of the body cavity, so it's the same stuff. So that splanchnic lateral plate mesoderm that lines the gut tube. But you see how that works? There's some pictures of it. Notice that there's double layer here, the splanchnic lateral plate mesoderm. That creates a stalk, and that's with us today. It ties down the intestines so they don't twist on each other too much. That's called the dorsal mesentery. Dorsal mesentery is important right there. It's already formed. There's a ventral mesentery, but we're not going to talk about that, or maybe later we will. All right, so now we're jumping ahead. I'm going to talk a little bit about folding, because remember I said lateral folding occurs at the same time the head and the cranial and caudal folding occurs. So to better see the gut tube, we need to look at it from the side view, or the sagittal, or the median view, and this is a median view. You can see right in the center of the this used to be the embryonic, it's still the embryonic disc here. Right in the center, it's open, so we have a vitelline duct here. This should be more narrow than this cartoon, but this region right here that connects the vitelline duct to the yolk sac, this is the midgut. But if you go out to let's go to the head fold region. There's a complete flat out tube right here. That's called the foregut, the one toward the head. That's going to develop into the trachea, the bronchial tree, the lungs, the esophagus, the stomach, the duodenum, jejunum, everything, ileum. And then in the backside, this is also completely folded. This is called the hindgut. And let me just point out again, remember we talked about the oropharyngeal membrane a couple videos back. That's going to be the future mouth. Then we have the cloacal membrane. That's going to be the opening to the anus and the vaginal cavity and the penile opening to go. These are still closed, but notice how these are bending. They used to be more like this one, but they used to be flat structures, and now they've bent. This one's bent 90 degrees. This one's bent completely 180 degrees. So that's what happens during this head and tail folding. But the key of this slide is the gut tube. The take-home message here: the gut tube is broken down into a foregut, which is toward the head, a midgut, which is the only part of the gut tube that communicates with the yolk sac, and then the hindgut is the back part here toward the tail fold. Okay. It's still a closed tube, so notice how the hollow tube is still closed. I just said that. It's closed right here. But this will be a mouth, and this will be the oral cavity, and this will be the tail, so fecal material will come out of here. But right now it's still closed, is what we're trying to say on this slide. What else? Are you kidding me? Does it form more? What else? The lateral folds. Yeah, something really important. Super important, the anterior body wall. What the heck is the anterior body wall? This is the anterior body wall on all of us. So you got a thoracic anterior body wall. The lateral plates would fuse right down the center of the sternum here, right down the linea elbow here, right down the center of the pelvic region. But that's the anterior body wall. And so the lateral plates better fuse together, or you're going to have openings in the chest and abdomen and pelvis if you don't. This little guy is fine. But yeah, so let's talk more about this. Problems occur when the lateral folds, for whatever reason, don't bind together. Big problems can occur. And so these are called ventral body wall defects. High yield for chiropractic medical boards. You got to know this stuff. Ventral body wall defects. Here they all are. And all of these result from failure of the lateral folds mainly to fuse together in the center. Sometimes it's a tiny little one, sometimes it's a giant one. So gastroschisis we're going to talk about. Omphalocele, super important ones. Ectopia cordis, hearts on the outside. of the thorax. What? The heart is literally outside. People live like that. Bladder extrophy. Bladder's on the outside of the body. Cloacal extrophy. Probably won't get to these, but we're going to talk about a couple of these for sure. None in a rabbit hole. Pathology rabbit hole. Let's go talk about the omphalocele. It's also called the ex-omphalos. Lang and Moore, two Board of Chiropractic Examiner books for chiropractors. So omphalocele, and everybody calls it this. Schlesinger, and everybody does. So as the intestines develop, or part of the intestines develop, and we'll get to the development of the intestines later, but I'll tell you right now, as the intestines develop, they do something weird. They need more room. They're growing so big. They actually grow right out of the belly button into the umbilical cord. The proximal portion of the umbilical cord is filled up with intestine, growing intestine. So that's crazy. But then they need to come back inside the abdominal cavity after a point. They can't be trapped out there. And you probably figured out already, if they don't get back in and get trapped out there, you got yourself an omphalocele. Okay, specifically it protrudes into the proximal, everything I just said. You can read this, but everything I just said. So let's take a look at one. So here's the anterior abdominal wall. Here's, I guess that'd be a right leg, a left leg. There's a little penis, which looks like it might have some trouble too. But look what we got. We got intestines coming out. Here's the belly button, and here's the cord, umbilical cord. So that's not good. That's an omphalocele. The key is it's got some membranes. It's got amnion and parietal peritoneum over the top of it, or peritoneum if you call it. Peritoneum, peritoneum, apples, or what is it? Tomatoes. But normally the intestines about week 10 go back in. So if this was a little 10-week-old embryo or fetus, this might be normal. But they need to travel back inside the cavity so that the umbilical plate can form and seal this off. So right now the umbilical plate can't close. Sometimes they don't return. If they get stuck out here at birth, you got yourself an omphalocele. Okay, this is an umbilical hernia, but it's considered a congenital umbilical hernia. So specifically, the herniate grows right through the umbilical ring, right through the center of the umbilicus. The belly button is surrounded by a umbilical ring, which turns into an umbilical plate with the passage of after you're born to give you some, so you don't herniate there. But in this case, you can't form any umbilical plate. Good board question. What covers an omphalocele? The amnion that we've already talked about, of the amniotic cavity, and then the parietal peritoneum. The intestines would have visceral peritoneum around them. So you could just say, I'm sure the question on the boards would just say something like amnion and peritoneum or peritoneum. Tomatoes. Sometimes these defects can be quite large, and you can even get liver herniating out of the belly button as well. So this poor little guy unfortunately didn't make it. It was stillborn. They have a massive omphalocele here with tons of intestine in here, and then you can even see the liver and who knows what else is in there. So not good. Here's the rest of the umbilical cord. So you can see it's in the proximal umbilical cord, inside the cord. Everybody good with that? And it herniates through the umbilical ring, right through the bullseye, right through the umbilicus. Gastroschisis does not herniate through the umbilical ring. It herniates outside. We'll look at that. But those are the classic difference between the two. What causes this darn thing? There's some theories. We don't know 100% sure. But there's a word you should know. A teratogen, or teratogen. That's how I say it. Teratogen. What is that? Cigarette smoke is a teratogen. So not good. So the current theory suggests that teratogen exposure at some point during the first 3 weeks, maybe, which you probably don't even know you're pregnant. You go out drinking like crazy. Maybe you got to have some genetic susceptibility to this too, or smoking, or pollution, or something, some trigger called teratogens. It triggers it, and it screws up the development of, or somehow it screws up the return mechanism that pulls the intestines back in. So the teratogen somehow causes abnormal growth of the lateral folds. Oh, this is the theory though. So the theory is that the mutation occurs with the lateral folds, and the lateral folds overgrow the umbilical ring and block it. So the intestines aren't able to come back in. And that's Carlson, which is our most evidence-based book. So the lateral folds grows too thick, and it blocks the umbilical ring, and the intestines gets trapped out there. But not everybody agrees on this, so this would not be a board question, a good one, because no one agrees on it. So when you're in obstetrics, you learn you always cut the cord at least 5 centimeters above the abdominal wall. And the reason is sometimes you can have an omphalocele or intestine herniated into the umbilical cord, and you can't even see it. And so you might, when you cut the cord, you might actually cut the intestine, and now you got a big mess. They got to call in the general surgeon to fix that. So you always cut way away from the abdomen when you're cutting a cord. So these children who are born with omphalocele, they have a huge chance of some other big problems as well. 75% of them have other abnormalities. There's a list of these things. Some of the big ones are trisomy 13, you'll learn in your genetics class. Beckwith-Wiedemann syndrome, another one. Dystrophy of the bladder is another one where the bladder develops outside of the body. So this one had an omphalocele, you can see here. Not a bad one. There's the cord clamped off, but the omphalocele is inside the cord still. But they had a bladder developing outside of the body cavity as well. These guys, of course, are really at risk especially if this ruptures during the pregnancy or during the delivery. You can get peritonitis and die from this really easily. So they're at high risk for premature delivery too. A lot of preemies seem to have these things. Now we got to talk about the pentology, means 5. Penta means 5. Pentology of Cantrell. The omphalocele is a member of that pentology. So children who have omphalocele, or gastroschisis for that matter, are prone to have these other common conditions. So an anterior diaphragmatic hernia, which can be no good. We'll talk about that in GIGU. They can have a cleft sternum. They can have pericardial defects like a ASD, or pericardial defects with the sac that covers the heart. And they can have cardiac defects like ASD, VSD, ectopia carda, where the heart develops outside of the ectopia cordis, where the heart develops outside of the chest cavity. What are the signs? How do you know if your unborn is going to have an omphalocele? There is and this is for gastroschisis. Is it for No, I don't think it's for gastroschisis. This is AFP. Increased levels of maternal serum alpha fetoprotein. They can do amniocentesis, and they can get to see if this protein is there. And if there's a high level of that, it's a pretty good indication that the baby's going to have an omphalocele. Very difficult to see in ultrasound, right? And until you get later, farther along. But some of them you can see. If they're big enough, you can catch it on ultrasound. You can only see his little nose here and in maxilla region and head, chest. So, but you can catch it. That's why you should always have prenatal ultrasounds. And if you're at high risk, you need to get amniocentesis. So operation is obviously required. It's fairly successful. It's actually really successful. The child is going to be left with a defect where the belly button used to be. But he looks like a happy, normal kid here. Just has a little kind of a scarred up umbilical because he had an omphalocele at one time. The ones that don't have any organs, like the liver coming out, usually do pretty good and can push the intestines back in. Because the intestines are still within the amnion and peritoneum, they typically do pretty good. The gastroschisis doesn't have peritoneum or amnion. The intestines are outside of that. Those kids don't do as good. The intestines gets damaged from the amniotic fluid, as we'll see here in a minute. Actually, let's see it right now. So gastroschisis is the next one. I should have put a pronunciation guide, but gastroschisis is how you pronounce that. And this one has nothing to do with the umbilical ring. And this is really weird. The right lateral fold, for whatever reason, refuses to fuse with the left lateral fold. So it's super rare for somebody to have a left lateral fold cause of a gastroschisis. It's always the right lateral fold. And if it doesn't meet with the left lateral fold and fuse, you got yourself a hole in the anterior body wall. It almost always happens right next to the umbilicus, the belly button, on the right side is where it usually happens. But it could happen up by the xiphoid process. It could happen down by the symphysis pubis. It could happen up in the chest region. You could have a gastroschisis up there as well. But most of the time it's down by the belly button. It's technically not an umbilical hernia because it's not herniating through the umbilical ring. The prevalence is about like Marfan syndrome, 0.01, so it's more rare. Females moms who are less than 20 years old, dramatically rises, 0.07, but still rare. More common in white and Hispanic babies than other nationalities. The unknown, the cause of this one is really unknown as well, but a popular theory is that the artery that supplies the right lateral fold gets screwed up. In fact, it withers away prematurely, and undernutrients to the right lateral fold stunt its growth, and therefore it doesn't have the growing power to grow and completely seal off the anterior abdominal cavity. Results in premature birth, premature birth are also much more common in these compared to omphalocele. So omphalocele can have omphalocele, you can have premature births, but this one, these babies tend to be preemies a lot of the time. Mortality is due to intestinal atresia, where the intestines get screwed up. Remember, we said in gastroschisis the intestines are exposed to amniotic fluid, which is caustic to them, so it wrecks the intestines, and then if the intestines get wrecked, they can't take in nutrients and they die of malnutrition. And other things, you can get infection, all sorts of things. There are increased levels of AFP in this one as well. So if you have increased AFP, hard to tell the difference between omphalocele and gastroschisis. One of the big complications here is small bowel obstruction, because there's nothing covered to these, as we'll see in a minute. So those affected, there is no hernia sac. In omphalocele, the hernia, here's the board question. What is the hernia sac made of in omphalocele? Amnion, parietal peritoneum. What's the hernia sac made in gastroschisis? Nothing. There's no hernia sac. There's nothing because this is a flat out hole in the body wall. Okay, there's nothing covering these things at all. The intestines are typically damaged, as we just said, by exposure to amniotic fluid. It's like caustic, like acid. Intestines don't develop right. Should have warned you, gross picture alert. This little guy survived, though, at least based on the piece that was, or the paper on this one. So suffered obviously a large hole just to the right of the belly button. You can see the livers come out, the intestines are out, baby's crying, so it's a healthy sign. They just pack that stuff back in there and sew it up. But again, the trouble is how damaged are these, later in life. Will the baby be able to survive, because will these intestines work? Can they take in nutrients? Will the liver have trouble? So only time would tell. We don't know child survived the surgery is all we know on this one. But that's a gastroschisis, very serious. Here's another one. There's no covering, right? There's no hernia sac. It's just there's large intestines come out of this, and it's to the right again. There's the cord. The cord is fine. There's nothing inside of the umbilical cord. But this stuff has come out on a big defect to the right of the umbilicus. Why? Because the lateral fold didn't meet the left fold. It didn't fuse and left a huge hole there. Everybody good with that? Another folding defect that happens up in the chest. So this is called an ectopic cordis. Occurs from failure of the lateral plates to fuse in the anterior thoracic midline. Oftentimes ribs don't form. A sternum may not form. And the heart literally forms outside the thoracic cavity. This is one of the members of the Cantrell pentrology, which include, again, ectopic cordis, diaphragmatic hernias, gastroschisis, omphalocele, a whole bunch more. Not a whole bunch. There's only pentology. There's only one more. Who are we missing? Forgot who we're missing, but here's an ectopic cordis. So that's a beating little heart, and you go on YouTube and you'll see little kids 6, 7 years old, and they still have a heart sitting out here. Sometimes it's down by the umbilicus. So, all right. So we're out of the anterior body wall defects. Let's look at sagittal plane. We're winding down here. Sagittal plane folding. I'm not going to go crazy onto this, but in the sagittal plane we get folding. We get a head fold and a tail fold. We kind of showed you a picture when we're talking about the gut tube. Now, unlike the lateral folding, which the folds meet and fuse together except in the very middle, the head and tail folds, they never go that far. So this folding is not as dramatic, and they don't fuse together. Here's just the start of folding here. There's the heart area starting to form. They don't have the cloacal membrane or the oropharyngeal membrane. Pretty flat disc, but we're going to look to see what happens when we get some folding going on. So now we got this head fold or the cranial fold or the cephalic fold. Folds under, and then the tail fold folds under like this. But that's it. It doesn't go all the way together. But it does. There's the heart that's forming. Remember, that was way up here, so that gets bent about 180 degrees. So it does do some folding, but not nearly as dramatic as the lateral folds. Structures change place. I already said the oropharyngeal membrane moves. It folds under, and so does the cloacal membrane. The cardiac region and the forming heart get folded under. So we'll talk about that more when we get to those sections. So that's about it for week 4 with regard to folding. But as folding's going on, we got so much other stuff happening. We got the pharyngeal arches. That really starts way back in week 3, so we need to talk about those. We got the heart starts forming in week 3. We talked about that, the cardiac region, but we're going to talk about that really soon. And then circulatory system, diaphragm formation. We've talked about the precursors of these things, except for the pharyngeal arches. Brain develops. The limb buds develop. We got a lot more work to do in week 4. So let's keep chugging away at this. Thanks for watching. Give me a thumbs up if you liked it. And we'll see you in the next one.